Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Shelley, would you like to introduce yourself?
Hi, I'm Shelly. I'm an undergrad at UMass Lowell, interning here at the Blum Center.
Thank you. Next, I'm going to just go over some housekeeping items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so you can hear our guest speakers today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Shelley, who will introduce you all today's guest speakers.
So joining us today is Dr. Sreevidya Bodepudi, who is a family physician currently completing her obesity medicine fellowship at Mass General Weight Center. Her clinical interests include health equity, preventative medicine, and adolescent medicine. She completed her medical education at Kansas City University of Medicine and Family Medicine training at Northwestern University. Her research interests include the realm of medical education and advocacy. Also joining us today is Dr. Karan Chhabra, who is a general surgeon and bariatric and minimally invasive surgery fellow at Mass General. His clinical interests include bariatric surgery, anti-reflux surgery, hernias, gallbladder disease, and benign gastrointestinal disease. He performs open and laparoscopic surgery. His research interests are in health policy and economics and include improving healthcare affordability and evaluating the comparative effectiveness of weight loss approaches. He received his undergraduate degree at Duke University, medical degree at Rutgers Robert Wood Johnson Medical School, and residency training in surgery at Brigham and Women's Hospital, where he received multiple awards for teaching and academic performance. He also completed a postdoctoral research fellowship and obtained his master's in health and healthcare research from the National Clinician Scholars Program at the University of Michigan. His research on surprise billing has been published in the New England Journal of Medicine, JAMA, and Health Affairs, and cited by outlets such as the New York Times, US Today, and CNBC. They join us today to give a talk on obesity. Please join us in welcoming them.
All right, good afternoon. Thank you so much for having both of us. We're so excited to be here with you both, or with you all. The title of our talk today is Obesity is Curable, the New World of Weight Loss Treatment. We recognize that there's been a lot of talk about this lately in our media, and we want to make sure that we are able to share some information about obesity and the new treatment options that are out there. So today we'll be kind of reviewing what does obesity look like, why is this important, and then we really want to highlight and focus most of our time on the different treatment approaches, recognizing that we need to use a variety of treatment options to help treat obesity. So understanding obesity. So why is this so important? It's really important for us to recognize that obesity has become a major problem in the United States. Compared from 60 years ago to now, obesity rates have now tripled. And now we're seeing over 40% of our population considered to have obesity. When thinking about patients who have overweight or obesity, who are over age 20, that's almost 3/4 of our population. So recognizing that this is a very significant burden that many of our patients face in our communities. We recognize that there are so many causes and reasons that play a role for patients to have this disease. There's a genetic component, recognizing that patients who struggle with obesity might have a family history that plays a role. There are many environmental components, recognizing how food, entertainment, activity in our culture has shifted, an immune component and medical component, thinking about how different medical conditions and medications can cause obesity, and thinking about endocrine and neurobehavioral components, so how hormonal changes or behavioral changes make it hard to adhere to lifestyle changes. So why is this so important? We recognize that obesity can affect us in multiple different ways. Thinking about this in two major categories, the first one being metabolic effects. We know that obesity can increase blood sugars, blood pressures, can increase cholesterol levels, and these can all have serious effects on our long-term health. There are also several hormonal irregularities that can occur too, and all of these play a role in our overall health long-term. Thinking about the physical aspects of obesity, we know that patients will sometimes notice more stress and pain in their joints. These forces can be applied in different settings as well. So thinking about sleep apnea, thinking about heartburn or GERD, thinking about how patients might develop more skin infections or could be more tissue friction. There's a physical component here that excess weight can pose on the rest of the body. So recognizing that patients struggle with both effects is really valuable in recognizing how do we need to treat this disease. So how do we diagnose obesity? What we most commonly use in our outpatient clinics is looking at something called a body mass index, which is known as a BMI. The BMI is a ratio of weight to height, and it's the most commonly used because it's so easy for us to do this in clinic. It's very simple to get a weight and a height. So what does this look like? So we describe patients as having a BMI between 18.5 and 24.9 as having a normal weight. Patients who have a BMI of 25 to 30 or 29.9 are considered to have overweight. And then patients who have a BMI of over 30 are then divided into class 1, class 2, and class 3 obesity. These classes help us differentiate between more severe cases of obesity. BMI is one marker that we can use. We can also use weight circumference or body composition analysis to help determine obesity as well too. So what do we make of this BMI? How does this look like in practice? We have an example here of a person named John. We're going to pretend that John is 5'9". And so what does this look like? So if John weighs 140 pounds, we would consider this patient to have a normal body mass index, to have no obesity. If John's weight increases to 170 pounds, he is now considered to have overweight, and his BMI is 25 at this point. If John just tips over a little past 200 pounds, he's now considered to have class 1 obesity with a BMI of 30. And then if John's weight gets closer to 240 pounds, this would be class 2 obesity, so more severe obesity. And then if John is ever over 270 pounds, we would consider this the most severe case of obesity, thinking about class 3 obesity. So what are our goals of treatment? First of all, primarily, we want to make sure we're treating other medical conditions that are associated with obesity. And we'll get to what this looks like in a few moments, but recognizing that there's several medical conditions that could be improved with the treatment of obesity can be really helpful for patients in long-term health. Our goal is also to help prevent those medical conditions from occurring. We know that preventing these medical issues can help with those long-term health aspects, help improving quality of life, which we'll talk about next, and help improve health outcomes overall. And really, we want to be able to improve quality of life. We have several patients who tell us that improving their weight can help them feel more mobile, helps them feel more involved with their family. And so we know that there can be several benefits from both a physical and a mental perspective here. So thinking about medical conditions associated with obesity, we take care of plenty of patients who struggle with high blood pressure, diabetes, fatty liver disease. And so oftentimes these medical conditions can be helped or improved with weight loss. So with patients who have high blood pressure, hypertension, or high sugar levels, we'll see here, these patients, if they can lose 0 to 5% of weight loss, these medical conditions could be improved. With thinking about patients with fatty liver disease or wanting to prevent type 2 diabetes, 5 to 10% of weight loss can be helpful. Thinking of patients who have cardiovascular disease or who have non-alcoholic steatosis, so thinking about more advanced fatty liver disease, these patients 10 to 15% of weight loss would be more helpful. And thinking about our more severe cases of obesity, so patients who might have type 2 diabetes and want to eliminate type 2 diabetes, who have any sort of heart disease, and they're higher risk for things like heart attacks and strokes, or patients who have a certain type of heart failure, these patients would benefit the most from greater weight loss, so closer to 15% of weight loss or more. So what does these percentages actually look like when we take a person? So we're going to take our patient again, John, who's 5'9", and we're going to say he weighs about 230 pounds. For John to improve his hypertension or high blood sugars or prediabetes, he would need to lose 5% of body weight. And so he would need to lose around 11 to 12 pounds to do that. If John wanted to improve his high cholesterol or fatty liver disease, we would encourage John to lose 5 to 10% of weight, which looks closer to 12 to 22, 23 pounds. For John to improve cardiovascular disease, we would encourage him to lose 10 to 15% of weight, which looks like closer to 23 to 35 pounds. And for patients who have diabetes or a certain type of heart failure, we would want them to lose the most weight, so over 15%. And so that looks closer to 35 pounds. And so we really share this to show you that this can be really hard to do by yourself. This can be really hard to do with kind of the traditional diet and exercise that has been encouraged. And so Dr. Chhabra and I really want to make sure that patients recognize that there's other treatment options to help improve and reach some of these really challenging goals. So thinking about different treatment approaches, it's really important for us to think about lifestyle management as like the basic foundation for all treatment when we're thinking about how do we counsel our patients. Thinking about how do we integrate or how do we have an integrative approach, thinking of our behavioral health colleagues and thinking about how from a mental health perspective, how can we encourage patients to make these changes and stick with these changes? What diet changes can we make? What activity changes can we make? And thinking about, do we need to advance or be more aggressive with our therapy levels as well? And so recognizing that there's so many factors that play a role into obesity, recognizing that there are so many causes and causes that play a role. And because of this, it's such a complicated disease. And so in order for us to really treat obesity, we really need a strong team. We need a lot of people to play on this team. We need dietitians, we need health psychologists, social workers, therapists, physical trainers, and then our physicians and surgeons who are kind of addressing obesity from multiple different levels and helping patients have the best outcome. So we want to touch base a little bit on nutrition. Our goal today is not to focus on all of the lifestyle changes. And the reason behind that is we really want to talk about the treatment options in the surgical and medication platforms. But we recognize that there's a lot of questions about nutrition. And one of the most common questions we get asked is, what is the best diet for weight loss? I know there's always a lot of talk about intermittent fasting, keto dieting, Mediterranean dieting. And our perspective really is the diet that you can stick with. When we say that, I don't like using the word diet. I like thinking about this as a lifestyle change. And so recognizing that whatever we eat and however we change our lifestyle, these are changes we will need to make for a lifelong change to occur. And so when we think about a best diet, we want a diet that's focused on reducing processed foods, reducing simple sugars, and increasing our fiber, protein intake, and kind of following some of those guidelines. And so for more particular support, I would definitely recommend talking to your doctor, talking to a dietitian about this. But we really think that the best diet is the one that you'll be able to stick to and follow long term. So thinking about patients who use lifestyle change as their primary treatment option for obesity. So we see that patients who have severe obesity can lose around 9% of total body weight over a year. This percentage is even lower for patients who have lower weight or a normal weight, or are overweight. And so we say that to kind of reflect a previous point, where sometimes patients need to lose or want to lose a certain amount of weight to help improve other medical issues. And that can be really hard to do with by just lifestyle changes. And that's where we'll kind of transition to a bulk of our program today. So we really want to talk about medication options today. And so, who qualifies for medication options? So by the guidelines currently, patients would qualify for medication options if they have a BMI of 27 and have another medical issue, such as diabetes, high blood pressure, high cholesterol. And then patients would also qualify if they have a BMI of 30 without any other medical issues. So our goal really when we think about medication management is we want patients to have gradual sustained weight loss. And if a medication is really helpful for a patient and they are seeing great results, we anticipate that this would be a lifelong tool in the treatment of obesity. Saying that if this medication is helpful, and it's helpful with the signaling, helpful with helping patients lose weight, we need to use it long term. And if we took that medication away from the patient, we would anticipate that they would gain that weight back because this was a really helpful tool for them to help maintain those lifestyle changes. So thinking about the medication options, I kind of want to divide this up between oral medications and injectable medications. So our oral medications that are FDA approved for the treatment of obesity include phentermine, Qsymia, Contrave, and Orlistat. We'll get a little bit more into what these medications do and how they might work for you. We'll also talk about these injectable medications that there's a lot of talk about lately these days. These medications that are FDA approved include Saxenda, Wegovy, and Zepbound. And I included two other medications, Ozempic and Trulicity, as these medications have been commonly used or talked about in the media as well. But these medications are not FDA approved for obesity. They are FDA approved for patients with diabetes, but still could be used off-label for the treatment of obesity. So why did we think this presentation was so important? Of course, we know there's so much hype and talk about a lot of these medications in the media. We know there's a lot of misinformation, a lot of questions out there. And we're excited that these medications are getting a lot of attention. But we also want to make sure that patients recognize that these are good tools for patients depending on your own health status. And so we try to really create a personal plan for patients. So kind of why are these injectable medications becoming such a big hype? So the first injectable medication was approved in 2014. So these medications have been around for almost the past 10 years. How do they work? So they work to increase a hormone called GLP-1. This is a hormone all of our bodies naturally create, but this injectable medication helps to increase that hormone to help better regulate appetite and help regulate insulin release. These medications are usually administered as a daily or weekly injection. And the most common side effects of these medications include pancreatitis, inflammation of the pancreas, gallstones, so stones forming in the gallbladder, nausea, vomiting, diarrhea, constipation, and heartburn. So there are definitely common side effects that are important to talk to your own physician about as well when thinking about this as an appropriate therapy option. These medications are really exciting for us because they've been shown to be so incredibly effective in treating obesity. These medications can help with patients losing anywhere from between 15 to 22% of total body weight loss. Dr. Chhabra will talk a little bit more about this, but these are approaching levels of what we can accomplish with surgery. Not quite there yet, but they've proven to be incredibly effective for patients. We're also seeing a lot of secondary benefits from these medications. So not only treating only obesity, but we're finding that patients are having better cardiovascular outcomes. It has been helpful for the management of diabetes. And currently there are studies undergoing that show a positive benefit for patients who have kidney disease and liver disease as well. So we're seeing a lot of other outcomes that are being improved with these drugs. Some of the most common questions and things I hear a lot in the media are, I just want to take a moment to answer some of these. So I think one thing I commonly hear is patients voicing concerns that these drugs are used for vanity purposes and not necessarily to help with other medical conditions. And we try to harp and recognize that we want to make sure that patients are meeting that medical criteria to prescribe these medication and that there's an actual medical indication for this. Patients also, or I think the media will also say that these medications are an easy way out and we don't want people to make diet and exercise habits. And we find that these medications help decrease hunger, help regulate appetite better, to make those lifestyle changes easier for patients to achieve. I see a lot of patients who are able to make a lot better changes and more effective changes being on this medication. I think a lot of people also have concern about long-term use of these medications. And so we commonly hear that I can reach my goal weight and then stop this medication. And that kind of goes back to the point that if these medications are helpful and useful for the treatment of obesity, they will need to be used long-term. And so we do recognize while these medications are great, there are definitely a lot of barriers to getting these medications for our patients. One of the primary issues that we see are these medications are very expensive. A 1-month supply is over $1,000. These medications are not covered by Medicare currently, and they're not covered by many private insurances either. And so many patients want to be on these medications, but we just can't make that happen from a cost perspective. Also, currently, these drugs are so popular that there are severe drug shortages and companies are not able to keep up with the demand. And so I know that's something we're currently experiencing at the highest peak right now, is seeing that a lot of patients who are on these prescriptions are not able to find their next doses. And this has been a big challenge for us to help patients with. And so I want to speak a little bit about those oral medications I discussed before, I mentioned before, phentermine, Qsymia, and Contrave. These medications work all a little bit differently, but they overall work centrally. So they work to suppress appetite by targeting different signals and different receptors in our brain. But overall, they help by helping decrease appetite, and they might also help with helping with cravings. They are all daily oral pills, and most patients lose an average of 5 to 10% of total body weight. So still a really good response, and this could be a really great drug for the right person. And so I think it's really a good conversation to have with your physician. And I want to hand over the slides to Dr. Chhabra here to talk about surgery.
Excellent. Thank you, Dr. Bodepudi, for getting us started, giving a great overview of obesity medications. I'm looking forward to sharing the other side of this with you. Let me just get my slides up on the screen. Good. So I will also start with some myth busting, because I think there's a lot of sort of misinformation out there on bariatric and weight loss and metabolic surgery. And I want to sort of tell you how things are currently in today's day and age. So I think the first thing I've heard about bariatric surgery is weight loss surgery, in other words. The first thing I've heard is concerns about its safety. It's a big thing to undergo surgery, and people are scared about anesthesia and so forth. But to get us started, I just want to reassure everyone that bariatric surgery is very, very safe. The mortality rate looking nationwide is 8 in 10,000. That's less than getting your gallbladder out. It's less than a lot of things that we do in this day and age. It's a one-day hospital stay. And frankly, I think it's safer than continuing to live with a lot of the diseases that come with obesity, including diabetes, cardiovascular disease, and so forth. So I'll just start with that it's safe. It is effective. When people undergo weight loss surgery, they can expect to lose 20 to 30% of their total weight and keep that off. And we're actually curing other diseases alongside obesity. That includes diabetes and sleep apnea in 60 to 70% of patients, and high blood pressure and high cholesterol, 40 to 60% of patients. We also can cure fatty liver disease, chronic kidney disease, reflux, the list goes on, and I'll talk about all that in a little bit more detail as we move along. And lastly, with all that in mind, it improves quality of life. People function better, their energy level is better, they're obviously able to fit into clothes, and they're happy with their appearance. And we've done studies showing that 97% of patients after they get weight loss surgery are satisfied with their decision. So I just want to preface everything that I'm saying with that and sort of dispel any myths that you may have heard about the surgery before I talk about it in a little bit more detail. You may also hear that people can sort of eat through their surgery and sort of chug ice cream and gain all their weight back. But I wanted to show you some data that might dispel that myth. This shows average weight loss on average, comparing people who underwent a gastric bypass, which is one of our operations, to people who tried medical weight loss. This looks at 11 years on average, and what you can see is that in the first year after surgery, people have this amazing weight loss, about 30% of their total weight. They do regain some. They might, regain 5% of that back. But then, as you can see, as we get out to 10 or 11 years, most of that weight loss is absolutely sustained. So these are durable operations as long as you use the surgery as a tool and continue to sort of stick to the diet and exercise modifications that we will talk about too. And then I think the other aspect of this that's worth considering is where would one be if they hadn't undergone the weight loss surgery? It's easy to compare. It's easy to say some people might have gained some or all of the weight back, but where would people be had they not gotten any treatment? What we know about obesity is that it's progressive. It's a progressive and relentless disease, and that people's weight usually goes up over time, not down. And so when you compare sort of the weight trajectory after surgery and the fact that some people regain some weight, again, you just have to think about where their weight might have been had they not gotten the surgery. So Dr. Bodepudi mentioned the insurance coverage around medications. It's an ongoing challenge, and there's a lot of people advocating for better coverage, and I expect that this will get better over time. But right now, many major insurance plans don't cover medications, and that includes the big ones, Medicare and Medicaid, and across private insurance plans, that's changing over time. In surgery, the coverage is also changing, but right now it's actually in some ways more generous. Patients need to have a body mass index of 35 with associated medical conditions or 40 without any associated medical conditions. And if you meet those cutoffs, pretty much every major insurance plan will cover bariatric surgery. That includes Medicare and Medicaid. And actually, this is also, like I said, a moving target, such that there's been some new guidelines that lower these BMI cutoffs to 30 with comorbidities, or 27 if you're Asian, and 35 if you have no other conditions. And so, again, there's a lot of advocacy and so forth happening in Capitol Hill and with insurance plans to try and make the operations more accessible for people. But right now, the coverage is quite good in terms of which plans cover it. And so the out-of-pocket cost just really ends up being about what people have as their deductible. It's not a monthly ongoing cost that you might face for the rest of your life. There's two major operations that I'll spend most of our time discussing because these are the most common ones out there today, and these are the most common operations performed here at the MGH Weight Center. Those are sleeve gastrectomy and Roux-en-Y gastric bypass. And I'll start with the sleeve gastrectomy because this is the most common one that we do. As you can see on the picture at left here, the stomach is usually a big organ, it's about the size of a football. And we use a surgical stapler to reduce that by about 70% and make the stomach about the size of a banana. It's actually a pretty straightforward procedure as far as the things that we do. It's about 1 hour in duration, depending on who your surgeon is and how they do it, and whether they're laparoscopic or robotic. It's about 4 to 6 small incisions that look a lot like this picture that's on the slide, although this is more of a representative photo. It's not one of our patients. And whether it's laparoscopic or robotic really doesn't make a big difference in the overall outcome, weight loss, recovery, and so forth. Open sleeve gastrectomies are almost unheard of, and so you can pretty much guarantee that it would be one of these minimally invasive procedures with tiny incisions. Now, compare that to the Roux-en-Y gastric bypass, which is an older operation. It's sort of the tried and true, you could say the gold standard weight loss operation, but it's significantly more complex. So what we do in this operation is, as you can see up here in the top left, we separate 90% of the stomach and we leave an egg-sized pouch where the food goes. We then reroute the intestine such that the small intestine goes up and is connected directly to that pouch. And then what's in the rest of the stomach, and this includes the bile, pancreas, juices, and so forth, those meet the food farther on down to the small bowel. So what we're doing is we're bypassing, or in other words, we're excluding most of the stomach and this first part of the small intestine from the food, such that these only contain bile and some digestive juices. And the food goes down and meets the bile and pancreas juices farther down the small intestines. So it's a more complicated operation, as you can see on the inside, but on the outside, actually, it looks exactly the same. And so I showed the exact same picture. It's usually 4 to 6 small incisions, again, can be done laparoscopically or robotically. People look and feel the same sort of, from a general standpoint as they're recovering from both operations. And if you meet with us in the Weight Center to talk about these, a lot of what we do is we compare the two operations. So the sleeve gastrectomy is a newer operation, but we've been doing it, as the most common operation. We've been doing it regularly for about 10 years. And it's been the most common operation for about 10 years. The gastric bypass is older, like I said, and has been around for longer. The sleeve is a shorter and more simpler operation. It takes about 1 hour compared to 3 for the gastric bypass. But the incisions and the recovery are very, very similar. Like I said, the average length of stay is 1 day for both operation in our center. They're both around 5 incisions that are, and they're tiny, tiny little incisions as you saw. It might be about 2 weeks off from work, 3, 4 weeks of gradual sort of return to activity and gradual diet advancement that I'll talk about too. And so, like I said, they're very similar from the big picture standpoint. And so, when we're talking to patients about which operation might be best for you, we obviously focus on the differences. The really major complications that are specific to the sleeve gastrectomy are that about 20 to 30% of patients may have new reflux or heartburn that they didn't have before. And it's hard to predict. Some patients actually start off with heartburn, and then when they lose a lot of weight, the heartburn gets better. Other patients may have no heartburn, but then they get the operation, and then they may have a new problem with reflux or heartburn. So that's the real sort of downside of the sleeve gastrectomy. And so when people have really, really bad heartburn, we try and move them away from the sleeve gastrectomy for that reason. The gastric bypass, on the other hand, is not, with that, reflux is actually not an issue. In fact, it treats reflux and makes reflux better. It's also better for diabetes. You get better diabetes control, better curates of diabetes, and we think probably more durable weight loss in the long run, as in it lasts longer and the weight regain is not quite as bad. But there are some specific, sort of side effects that we always talk to patients about as well, which is that there can be ulcers at the connection between the small intestine and the stomach. And for that reason, it's really important that patients don't smoke for their entire life, and they also can't take non-steroidal pain medications like Advil and Aleve. In the way that we rearrange the bowels, there's also a possibility of bowel obstructions where the bowel sort of twists under those new connections. The sort of incidence of those lifelong is less than 10%, probably closer to 5% as a lifelong risk. But it is real, and those are important. So we have to talk to people about those, and people who have a history of ulcer disease, people who need non-steroidal medications for arthritis or other issues, for instance, we often suggest to them that the bypass is not the best operation. Going back to the sleeve gastrectomy, as I said, it's an easier operation for us as surgeons. It's even though the recovery for both is about the same. If you need non-steroidal pain medications, you can take them with the sleeve gastrectomy. We don't recommend smoking for anybody, but if you were a smoker who's not been able to quit, we definitely would not offer a gastric bypass, and we'd sort of nudge you more toward the sleeve gastrectomy. There's some other complications that can happen with either operation that are usually not, too big of a deal, but worth mentioning. Malnutrition is a possibility with either operation, including vitamin deficiencies. It's a much bigger deal with the gastric bypass, and so it's very important to take a bariatric multivitamin, especially after the gastric bypass. Gallstones can happen in about 1/3 of patients after either operation, and if that's the case, then you may need to get your gallbladder out. Dehydration is a very common issue, especially in the first month after surgery as people are adjusting their eating and drinking pattern. And so we spend a lot of time educating patients on that. The serious complications, luckily, are quite rare. And that's why, going back to the safety of this operation, having a serious life-threatening issue is very, very unusual. The worst thing, or one of the worst things, would be a leak from where we staple the stomach. That's about 1 in 1,000, so extremely rare from either operation. Blood clots have also gotten more rare. We use blood thinners around surgery to prevent blood clots. And then lastly, sorry, I'm just having a little bit of issues seeing my slides now. And then lastly, hernias. You can either get a hiatal hernia or an incisional hernia. Those are quite rare. And if they do happen, they're usually not that big of a deal. And what sort of weight loss are we talking about? What can we sort of say about the effectiveness of both of those? This chart compares the weight loss from the sleeve gastrectomy to the gastric bypass at about 5 years from surgery. And as you can see, initially the weight loss is very similar. As you go out farther along, you can see that the gastric bypass has a slight advantage, again, about 30% total weight loss, whereas the sleeve gastrectomy is a little bit lower. But all in all, we're talking about 5% of people's total weight. So if they were 200 pounds, you're talking about a 10-pound difference. And I usually tell people not to worry too much about the weight loss, not to over emphasize the weight loss when they're deciding between these operations, because that 10 pounds could, you could also achieve that 10-pound difference with really, sticking to the diet or really sticking to your exercise. I wouldn't choose the operation just based on that alone. It's really more of these other specific factors like reflux and medications that you're on, your overall health status, and your overall risk tolerance that helps us sort of make this decision with people. And I think the big take-home point here is that these operations, neither of them, they're actually really not about making your stomach smaller. That's not at all the most important aspect of these. It's true that they do make the stomach smaller and that we have to have smaller meals and so forth, but they really work on hormones and physiology in a way that actually a lot of these medications do too as well. They make you feel fuller. They make you feel fuller for longer. They sort of decrease appetite. And we think that that's why they're really effective in the long run, is that, a lot of the hormones that actually affect hunger come from these parts of the stomach that we remove or exclude. And so I think about these as more hormonal operations than simply making the stomach smaller. And I want you to sort of think about them as well. And that's why a lot of the side effects are similar to the side effects of medications, because they're doing a lot of the same things. It just happens that surgery affects more pathways and more hormonal mechanisms and so forth than medications do at this point. But the medications are changing with time and they're becoming sort of more sophisticated as well. So as I sort of alluded to earlier, these are complicated decisions, and we spend a lot of time in the clinic talking to patients about which procedure might be right for them. I sort of gave you some of the medical considerations that might push us one way or another for a given patient, but a lot of this comes down to individual patient preferences, sort of where do they fall on sort of the risk taker to risk averse spectrum. What is their overall health status, and then what is sort of the surgeon's risk tolerance as well. And somebody who might have a lot of weight to lose, for instance, some surgeons might say, let's do a gastric bypass because it's a better weight loss operation. Other surgeons might say, let's do a sleeve gastrectomy, let's see how much weight they lose. And if they still need to lose more weight, we can actually convert these operations. We can convert from a sleeve gastrectomy to a gastric bypass for additional weight loss. And oftentimes these operations are easier once someone's already gained a bunch of weight. Those are all sort of trade-offs and decisions that you could discuss with us in the weight center if you're interested in these options. There's a risk calculator as well that we can sort of punch in your information, any illnesses you may have, your weight, diabetes, and so forth, and we can even predict how much weight a patient might lose, whether or not we'll be able to cure their diabetes, whether or not we'll be able to cure their hypertension, and so forth. So this is a really useful tool that we use often in the office. And as I sort of alluded to before, the surgery is a tool. It's not a quick fix. It's not a silver bullet. It's really what we'd say is it's sort of a kickstart to a year and a lifetime of lifestyle modification. So with the surgery, you come into our weight center. Patients will work with our dietitians, work with our psychologists. We'll really try and reinstitute some healthy behaviors. And then the surgery will really jumpstart that process as well. And but then it really sort of falls down to the patient and their support network and so forth to maintain and sustain the weight loss in the long run. A little bit more detail on our process. So people who are interested in weight loss surgery, they first start off with a Zoom seminar. It's similar to what we're doing right now, learning a little bit more about the process and what it entails. We run people's insurance to make sure, every insurance has different sort of requirements before people get bariatric surgery. Some insurance plans require 6 months of medical weight loss before. Some insurance companies just let us go straight through with our process. There's a dietitian that everyone meets with, and we sort of learn people's eating pattern prior to surgery, and everyone meets with the psychologist as well. And if they do have mental health issues, it's not at all to exclude them. It's just to sort of put them on our radar, and so that we can come up with a good plan to help manage those mental health issues afterward. Immediately after surgery, we always check in the operating room to make sure that there's no question of leakage from the staple line. As I said, that's the biggest complication, but most of the time we're able to see and address that in the operating room. It's a 1 to 3 hour surgery, and the very same day, people are up, walking out of bed, drinking sips of liquids, and then usually they're home the very next day. We check blood work, and we make sure people can keep down liquids before we send them home. And then once they go home, they go on a liquid diet. Initially, it's clear liquids and then protein shakes for 2 weeks as they sort of adjust to the changes in anatomy and the changes in the drinking pattern. And then we gradually advance to a soft diet and more of a regular diet over the coming months. And as I said, this is a lifelong journey. You know, people do really well over time, but it's important for them to sort of to stay plugged in with us and with their own doctors, because there's things that we need to keep track of. That includes checking labs to make sure that there's no ongoing vitamin deficiencies. We also make sure that, you know, people's other medical conditions are improving over time, like their diabetes and blood pressure. It's really a sort of a whole holistic package. You know, we follow with the dietitian and the psychologist. You'll see our surgical team as well to make sure there's no complications. Patients who get bariatric surgery are on a vitamin for life, and we really do feel that healthy diet and exercise is the cornerstone of getting that initial weight loss and maintaining it over time. So with that, you know, sort of a few take-home points, and then we're happy to open the floor to questions. One is that we really think of obesity not as just a cosmetic problem. You know, we think obesity is a phenomenon that affects every single part of the body, and it affects people's overall quality of life as well as the quantity of their life lived. But now, as you heard from us, obesity is curable, both medically and surgically, and we now can achieve the amount of weight loss that one needs to cure a lot of the conditions associated with obesity, including diabetes, high blood pressure, sleep apnea, and so forth. We're really talking about cures now, not just sort of making them less severe or kicking the can down the road. You know, with these advances, though, I will say that these are lifestyle change is still the foundation or the bedrock of obesity treatment. You know, I think we appreciate more and more that it's a biological disease and that we have these tools at our disposal to help with the weight loss, but ultimately it takes, you know, buy-in from the patient and their family and support network. And so, and the diet and exercise is no less important. We just realize that these other treatments are really important for getting people to their goals. And so happy to stop there and take any questions. Put up the phone number for the MGH Weight Center for anyone who wants to learn more and potentially get involved in obesity treatment with us. It's 617-726-4400. So thanks everyone for listening. I really appreciate you joining us and spending this afternoon with us. We're happy to now stop and answer any questions.
Thank you so much. We're now at the end of the session. If you have any questions for Drs. Chhabra or Bodepudi, please feel free to enter them in the chat. We have a question regarding BMI numbers. Have the BMI numbers defining levels of obesity changed over the years, like blood pressure numbers have changed, or have they remained the same?
I'll defer to Dr. Bodepudi for that one.
That's a great question. I don't think the classes, when we think about severity of disease, have necessarily changed, but there have been some more recent guidelines to help differentiate looking at severity of obesity, especially when looking at different ethnicities. So in South Asian and East Asian populations, there are actually more aggressive BMI targets, thinking that a BMI of greater than 23 actually qualifies someone to be having overweight, and a BMI of over 28 is having obesity. So more aggressive for certain ethnicities, but I don't think there's actually been a general population level change, as Amy described, for high blood pressure.
Right. So I think the definition of obesity hasn't changed. As we said, those classes of obesity based on BMI are the same that they've always been. But I think the community is moving toward treating obesity at a lower BMI. I think we're increasingly appreciating the effects of obesity and metabolic disease at a lower BMI, and so I think, and now we have treatments for it. And so I think our threshold to intervene is we're much more aggressive about it for the same BMI.
Thank you. We have a question regarding medication, long-term use of medication. Do you know if after long-term use of medication, whether a person would plateau or where they maintain a certain weight no longer lose?
Yeah, absolutely. So looking at a lot of data that we have background for especially these new classes of medication, the amount of weight loss that we talk about is usually occurring at the 1 year mark. And that's usually around when we're starting to see that plateau of weight as well. In a clinical setting, that can happen earlier or later. So it's really hard to kind of give that clear answer. And we have patients who plateau before and after that too. And so eventually we do expect to see a plateau and see a plateau in the response. At that point, we talk to patients about, is this appropriate? Is this new weight still a better weight than they were before? Do we still want to be more aggressive with treatment? Do we want to think about adding something else? So whether that's another medication, whether that's lifestyle, whether that's a surgical intervention. So I think there's still room to help address that if weight still continues to be a concern, even at that new weight.
Thank you. And what are your thoughts on gummies that claim to help with weight loss that, many celebrities, the media, businesses are marketing that are FDA approved? Do they contain the same medication as the medications that you shared today?
Another great question. I don't have too much experience in this area, but from what I've seen so far, most of these gummies do not have the same medications that we talked about today. The medications that we talked about do require more medical management. There are definitely side effects that require closer monitoring, and so they do need to be prescribed. They're not available over the counter like that. In terms of what are actually in these gummies, that's a great question. I don't have a great answer for you in terms of even thinking about safety per patient too. So generally, patients do ask about these things. My general answer is I would rather treat you with the FDA-approved treatment option. When we think about supplements in general, there's no regulatory body for them. And so it's really hard to understand and discern what is in the supplements and the quantity of that as well. So I don't have anything additional to add there, but my words of advice would be to steer clear.
Thank you. And is there information or data available regarding the percentage of weight loss patients who also need assistance of medication after their surgery?
That is a good question. Offhand, I don't know that statistic, but I think it begs a bigger question, which is, are these binary, one or the other? And they're certainly not. I think we consider these treatments now as going hand in hand. A lot of patients are coming to surgery after having spent time on medications and sometimes having had very successful weight loss, but wanting additional weight loss, or not having had success and then coming to surgery for that reason. And then following surgery, we usually give it about 1 year for people to reach their maximum weight loss. That's usually when we get sort of the best number. And then at that point, if patient's body mass index is still above 30, we may sort of have a conversation about getting medications at that point. We sort of aim for a body mass index less than 30. And so as you can imagine, if you're starting off much higher, if you're starting off at 50 or 60, we can sort of predict that the surgery alone won't get you below 30, but perhaps surgery plus medications will, or perhaps we'd consider a second, more aggressive surgery as a revision later. But if you're starting off lower, if you're starting off at 35 or 40, there's a really good chance that we can get you to what we consider a healthy weight.
Thank you. Are there any advantages of injectable medications versus oral?
Absolutely. So I think there's a lot of excitement about these injectable medications because in the large group studies, we're seeing that patients have more of a weight loss effect with the injectables compared to orals. However, I'd like to remind everyone that these are large studies, but in a clinical setting, I have patients who respond beautifully to oral medications and reach those percentages as well. So I think it's really good to have a conversation with your provider, with your physician about these things. But the excitement about these injectable medications is we're seeing a lot of a more robust weight loss response, and we're also seeing improvements in some of the other secondary outcomes. So thinking about kidney disease, heart disease, diabetes management. So if patients have any of those other medical issues, these could be a better tool.
Is it true that the injectable medications are also better tolerated in terms of nausea and so forth?
I think so. The injectable medications generally cause more nausea, vomiting, diarrhea than some of the oral medications. Some of the oral medications are not safe if patients have high blood pressure already. And then they can also interfere with some more psychotropic medications. So if patients have anxiety, depression, bipolar disorder, there needs to be more of a conversation around that too. So I think side effects are definitely another considerable option. We take care of a lot of patients who have gained weight as a result of being on medications that are being used to treat bipolar disorder or depression, and that's another good example of where those injectable medications would probably be the safer option.
Thank you. And with a follow-up question on that, would one ever need to switch from an injectable medication to an oral medication?
That's a great question. It's hard to say need per se. I think it's really individual based. When we have these large scale studies, we see a lot of patients have a great weight loss result with these injectable medications. But in a clinical setting, patients don't always respond like we anticipate them to. And so like from a personal experience, I've had a patient maybe not respond so well to an injectable, but had a better response to an oral medication. So it's hard to predict outcome. I think the conversation really needs to be like, what is working? What is effective for the patient in front of me? Are they tolerating these medications well from a side effect perspective? And is it still safe for them to use? And then lastly, can they continue to get this medication? With access and affordability being a barrier, I'd rather my patient be on a treatment that they can get than one they can't.
Thank you. We have a question regarding the weight center. Is there a wait time for a new referral to the weight center?
Yeah, so currently on the medical side, there is a wait time. I believe it's around 1 year. It might be a little less right now. The other kind of barrier to consider is because we've had such a long wait time right now, we're only accepting new patients who have a primary care physician through the MGH system. This is a temporary thing, and we will be removing this hold hopefully as we're able to improve access, but we're doing that to kind of help restrict the time limit. I don't know if Dr. Chhabra, I think it's a little different on the surgical side.
Certainly, if you're getting a surgical appointment, you can have anyone as your primary care doctor. It doesn't need to be within the MGH system. And the wait time is considerably lower. I couldn't provide you that number immediately, but I think we can get people in within just a few months, a couple of months.
Thank you. What are your thoughts from government and insurance companies who offer cost coverage for patients to join guided exercise programs with physiotherapists to provide ongoing life management behavioral changes?
I think it's a great first step. I kind of like Dr. Chhabra and I hopefully reiterated is that lifestyle change is really the foundation when we're thinking about any of these added treatments. So making sure patients have access to these resources, I think is extremely beneficial. But I think it's important to realize for most patients, it's not enough. And that's where medication and surgical options really play a role. So still very important, but in many cases, we need to be more aggressive in our treatment.
Thank you. And while we wait to see if there are any additional questions in the chat, do you have any final thoughts you'd like to share with the audience?
Maybe we can talk about sort of who, if people are interested in weight loss medications, to what extent are primary care doctors prescribing these if they're having trouble getting into a place like the weight center, and what are other sort of safe and unsafe ways to get weight loss medications for those who are interested?
Absolutely. I think, so of course, with a lot of these medications in the media, I think primary care doctors are definitely forced to kind of learn more about these topics and help fill that gap. Absolutely. I will say more commonly now than 6 months ago, I see so many patients who are started on treatment and then transitioning to the weight center and have started treatment with their primary care doctor. So I think this is becoming more and more popular. From our clinic, we are also doing more outreach to primary care doctors to help with workflow, help teach doctors about these medications, help support some of the nitty-gritty behind the scenes that we need to manage, whether that be prior authorizations, accessibility. So there is work being done to help reach out to primary care to make this a more feasible situation as well. So I think starting with your primary care doctor is very reasonable. In this telehealth world, there's a lot of telehealth companies who are taking over in this space as well. And so I think one example would be like Weight Watchers recently. And so I think there is room for reputable companies who have a telehealth platform to be seeing patients. My word of advice and cautionary with that is I think I just recommend patients look for providers or look for services that are offering appointments with physicians, providers, making sure that there is some sort of medical oversight, making sure that there's continuity. We want to make sure we're seeing our patients every 3-6 months. This isn't something where we give you the medication and run free. It requires a lot of careful monitoring for this too. And once again, making sure that the company we're working with has a lot of lifestyle support because we want to make sure we're thinking about quality of weight loss as well. It's really important to think about lifestyle changes, making sure we're maximizing the amount of fat loss that is occurring while preserving muscle loss. And naturally, when we're having this process, patients are losing both, but that's where the quality of weight loss is so important. And that's where the role of a physician is really important in this care.
Thank you. I don't see any further questions in the chat, so I think it'd be okay to end a couple minutes early. Thank you so much, Drs. Chhabra and Bodepudi, for joining us today. This was extremely helpful. And for everyone that took the time to join us today, thank you so much. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.